Good morning or good afternoon, depending on where and what time you're watching this lecture. My name is Dr. Alexis Batter, and I'm a senior fellow with the program in Global Surgery and Social Change. This will be our first lecture of Module 1, talking about the different types of clinical research studies. And today our main objectives are to understand what clinical research is, to review the different types of clinical research studies, or get a broad overview of a majority of them, and then to discuss the benefits and disadvantages of each type of study themselves. Today, our course outline is a little bit longer than some of the other lectures we have for the rest of this year-long course, but we'll start with an introduction to clinical research. We'll talk about animal research studies, case reports, case series, case control studies, cross-sectional studies, cohort studies, randomized controlled trials, and then we'll finish with briefly discussing systematic reviews and meta-analyses. When we think about clinical research and what it is, clinical research is research in which people or data or samples of tissue from people are studied to understand health and disease. This research helps find new and better ways to detect, diagnose, treat, and prevent disease by allowing physicians to collect data on usual and unusual events, conditions, or populations, and test their observations in the clinical setting as a hypothesis. When we think about the different categories of clinical research, they can be broken down into descriptive studies, where these are often the first studies in a new area of medicine, and investigators do descriptive studies to describe the frequency, natural history, and possible determinants of a condition. These studies often observe clinical findings but do not have a comparison group, whereas analytical studies are studies that have a comparison group or control group. And both of the analytical and descriptive studies fall under a broader category known as observational studies in clinical research. Finally, the second large category of clinical research is experimental, and in this, clinicians or researchers assign a condition or an exposure to participants and then have participants who do not have the assigned exposure and follow them over a period of time. And these are typically thought of as either randomized or non-randomized controlled trials. Sometimes it's helpful to look at things in a broader diagram and in a different way, and so this just shows the same information with a little bit more detail that research methods in clinical research can broadly be thought of experimental, off to the left where you see randomized controlled trials, fall under this non-randomized controlled trials, as well as animal research or observational, which is broken down further into two larger categories: analytical, like we discussed, where there's a control or a comparison group, and descriptive studies. So now that we know about the different types of clinical research, why do we do research as clinicians? And this is a nice quote that sums it up pretty nicely, but more briefly, clinical research allows us to understand and explore the problems that affect our patients, communities, or health systems in a way that can lead to improvements in the quality of the healthcare we provide. On a more detailed level, the information gained from clinical research can help guide our clinical practice. It can help us identify high-risk patients, develop clinical protocols to triage or treat disease that we see on a day-to-day basis. It can help us improve the health systems that we work within. A lot of research is focused on quality improvement. We can even look at the cost of the interventions we're providing and see how that can be improved. And then in addition, clinical research often leads to the development of new treatments or procedures that improve the livelihood of our patients. Before we go on to talk about each type of clinical research study, there are a few key terms that we need to define before we continue on in this lecture, and those terms are retrospective, prospective, bias, and confounder. Retrospective and prospective typically refer to the timing of a study, whereas bias and confounders are things that can affect how you think about a study overall, and are important things to consider when you're interpreting the results of different research studies and when you're designing your own studies. When we think about the definitions of retrospective and prospective, again, these refer to the timing of when exposures and outcomes are measured throughout a study. A prospective study watches for outcomes over time, such as the development of a disease during the study period, and relates this to other factors such as suspected risk factors. This study usually involves taking a cohort of subjects and watching them over a long period. For example, if we followed a group of patients who were smokers, and we knew they were smokers at the beginning, that would be our exposure. We then would follow them over the next 20 years of their life to see if they developed lung cancer. This would be our outcome, and that would be an example of a prospective study. On the other side of the spectrum is retrospective studies. And these are typically thought of as historical cohort studies, where we look backwards and examine exposures to suspected risk factors in relation to an outcome. And that outcome is known at the start of the study. So, for an example, if we knew that we looked at all women who had a surgical site infection after their surgery and their outcome was a surgical site infection, we would then go back in time to try to identify risk factors for a surgical site infection, and one of those might be smoking. So we go back into their charts and see if they had any history of smoking prior to their surgical intervention. In addition to understanding the timing, as in the words retrospective and prospective, it's important to think about how bias can be introduced into different research studies. Bias occurs when there's a systematic difference between study measurements and the true population values. So there's a lot of different types of bias. The first is publication bias, and this is that we tend to only see reports or papers that are those papers that report a significant finding are those that tend to be published, and those that don't find a significant difference or a significant change after an intervention aren't published. So a majority of the literature is only publishing those significant findings, and this can bias what we see in our literature reviews. The second type of bias is confirmation bias, and this is when during the interpretation of a study and when researchers are looking at data, they consciously or unconsciously look for information or patterns in their data that confirm the ideas or opinions that they already hold prior to their analysis. The third type of bias is selection bias, which is where there's a systematic difference between those selected into the sample and those not selected. For example, if you were going to study a disease at one hospital, but that hospital only had male patients, then you would have selection bias because you weren't including any women in your study, and this wouldn't be representative of the population as a whole. And the last type of bias is recall bias. And this is where differences in reporting experiences between those who have and those who do not have the outcome of interest. We typically see recall biases affecting retrospective studies. Lastly, we just want to talk about confounders, which are a difficult concept to sort of wrap your mind around, but confounding occurs when association is made at the analysis stage between outcome and exposure, which in reality may be a result of a secondary exposure that was not included in the initial analysis. So for example, in a study, it may be found that people in one town have higher rates of oral cancer than another. But if you were to interpret this to mean that oral cancer was dependent on the area of residence, that would be incorrect if people in the first town are known to be heavier smokers than people in the second. So the confounder there would be the smoking status of the people in each town. And confounding can be minimized at the design stage with randomization, matching, and stratification. And as I said, confounding and bias are difficult concepts to understand. So we've included an additional supplemental article that you can read about these concepts. But we'll continue to refer to bias and confounders as we talk about the advantages and disadvantages of the different types of clinical research. So just as in biology, there's a taxonomy or a hierarchy that can be used to categorize most animals, you can also categorize most studies. But in order to do so, you have to know the study design. And just as in biology, as anatomy dictates physiology, the anatomy of a study can determine what it can and cannot do. And depending on what a study can and cannot do, allows us to decide what level of evidence it can provide for clinical practice. And in this diagram here, studies with the highest level of evidence are at the top of the pyramid, and those with the lowest level of evidence are at the bottom of the pyramid. And for the rest of this lecture, we'll start from the bottom and work our way towards the top, briefly talking about each type of study, where it falls in the categorization scheme of clinical research, and some of the advantages and disadvantages of each type of study. So we'll start with animal research, which, as we said before, will fall under the experimental arm of clinical research. And an example of animal research that's been done in the past is a study that looked at how effective chloroquine was in treating a viral infection in an animal model. Animal research typically describes research involving vertebrates such as cats, mice, frogs, pigs, and primates, and most animals that are used in research are specifically bred to be used for medical research. Animal studies have led to a number of clinical advances, including the use of insulin as a treatment against diabetes, and that was found in dogs. and the discovery of the effects of anesthesia in laboratory rats in the 1920s and 1930s, respectively. Another benefit of animal studies is that there's no risk to human life, and they allow for the testing of both the safety and efficacy of interventions prior to the use in human subjects. However, some of the limitations of animal studies is that they're often expensive and time consuming because the animals used have to be carefully selected or bred in order to be used for research. And now that we've talked about animal studies, the next studies that we're going to discuss that are sort of the next level of evidence above them are descriptive studies like case reports, case series, and cross-sectional studies. The results of all three of these studies often show how people or groups of people develop a disease or condition over time. And again, they're considered some of the lower level of evidence because they only describe things, they don't compare to a control or a comparison group. So you can't really determine causality or say that one exposure leads to an outcome or a disease in these types of studies. So again, we'll start off to the far hand right of our diagram with case reports and case series, which again fall under the descriptive arm of the observational studies. One of the first case reports was reported in the 1800s, and it was of the elephant man who's pictured off here to the right. The case report described his symptoms and his overall appearance, which included macrocephaly, hyperosteosis of the skull, hypertrophy of his long bones, and thickened skin and subcutaneous tissues. And just like this case reports in the current day are often reports of the natural course of a novel or unusual case, and can include anywhere from 1 to 3 patients, and are usually some of the first written descriptions of a new or novel disease or treatment. Similar to case reports, case series often involve a group or series of patients. We typically think of this as more than 3, and they describe the treatment, their outcomes, and their presenting symptoms. And patients in case series can be included consecutively, so one right after the other, or non-consecutively. The benefits of case reports or case series is that they are relatively quick and inexpensive to perform and can lead to the recognition of new diseases and adverse effects of treatments. For example, the initial outbreak of the community-acquired pneumocystosis carinae pneumonia, which was an initial manifestation of HIV, was initially published as a case series with 11 patients. However, some of the limitations of these studies is that they're only descriptive in nature. And as I mentioned before, you can't determine associations between an exposure and an outcome. This has to be done with some of the more rigorous studies that we'll go on to discuss in this lecture. In addition to case reports and case series, the last type of descriptive study in the observational arm are cross-sectional studies. Cross-sectional studies are carried out at one point in time or a snapshot in time, and they're usually conducted to estimate the prevalence of the outcome of interest for a given population. They're commonly used for public health planning, and data can also be collected on individual characteristics, including exposure to risk factors, alongside information about the outcome. So in this way, again, we think of cross-sectional studies as a snapshot of the outcome and the characteristics associated with it at a specific point in time. So an example is in 2010, data was collected from 179 countries with over 400 pieces of, or 400 indicators to see what macrostructural factors were associated with maternal mortality. And they found that education, trade, and governance were the most important factors associated with maternal mortality across the globe. So these are used to sort of get a broader picture of the prevalence of a disease or a outcome. And some of the benefits are that they're relatively inexpensive to do and they take little time to conduct, and that they can estimate the prevalence of an outcome of interest because the sample is usually taken from the whole population, and you can assess many outcomes and risk factors at once. And they're very useful for public health planning and understanding disease etiology for the generation of hypothesis. And there's no loss to follow-up within these studies. Some of the limitations, though, is that it's difficult to make a causal inference to say that an exposure leads to an outcome because you're only looking at a snapshot in time. You're not following patients over time or looking back in time to determine that. And because it's only a snapshot in time, if you chose a different time frame, you might have different results. And then lastly, if there is longer lasting diseases, any risk factor that results in death may be underrepresented because patients may not die from that disease if it takes a long time to do so. You may not catch them within your snapshot. And finally, it's just really important to remember that with cross-sectional studies, because they're only carried out at one specific time point and there's no indication of the sequence of events, whether the exposure occurred before, after, or during the onset of the outcome or disease that you're looking at, you can't make an association between the exposure and the outcome. The next type of study that we're going to look at are case control studies. So these still fall under the observational arm of research studies, but in comparison to the descriptive studies, these studies will have a control group as mentioned in their name, and they fall under the analytical arm. So the purpose of case control studies is to establish the association between exposure to risk factors and disease. One of the first reports of a case control study was in the 1950s, where Drs. Dole and Hill performed a large case control study in London, identifying patients who had cancer. And for each patient who had lung cancer, they then found a control patient or a patient without cancer. And they interviewed all participants, those who had cancer and those who didn't, about their smoking habits. So this is an example of a case control study where the purpose is to establish association between exposure to risk factors and disease. And these typically tend to be retrospective in nature. And just to sort of give an example of the difference between a case control study and a cohort study, which we're going to discuss in the following slides after we finish with case control studies, is this nice figure that sort of keeps everything organized for you in your brain. This figure on the left shows when data is collected, and that's for each type of study. This is represented by the question marks. The person represents when in time the researcher begins the study, and a black circle or white circle represents whether the disease or exposure is present in the study population or the control population. So you can see that a case control study, the members of the population with the disease are selected into the study, and the risk factor information is collected retrospectively, just like we saw in our example. Whereas in a prospective cohort, the patients, their exposures and outcomes are followed over time into the future, and we just see whether or not they develop a disease. And then if it's a retrospective cohort, again, we're looking back in time, but we know that patients have had the exposure. We're then looking to see if they develop the disease. So this is a nice sort of figure to look at all three studies all at once. This is another way to think about a case control study. In the present time, in the time the researcher begins the study, we have the cases that we know we want to look back on. Then we find controls that match our patients with the disease or outcome of interest. We look back in time to see whether or not they had an exposure. The nice thing about case control studies is that they're relatively quick and inexpensive to do. They're very good for rare disorders or disorders that have a long time between exposure and outcome. And the case control study design is often used in the study of rare diseases as a preliminary study when there's little known about the association between a risk factor and the disease of interest. Some of the disadvantages of case control studies is that they're difficult to overcome some of the potential biases and confounders that are inherently present. You have to be very specific about the selection of both cases and controls who represent their respective populations, and that's very difficult to do at times. It's sometimes difficult to infer causality, and there's not always information on the chronology of the disease and the exposure. And these studies are not always ideal for studying risk factors, which are rare in populations. So they're better for studying things that are very common, like smoking or driving without a helmet, things like this. And then The last part is these studies are not population-based, so it's impossible to calculate the incidence of disease from a case control study. And we started to briefly talk about cohort studies when we were comparing them to case control studies, but that'll be the next type of study that we talk about in this lecture. Again, these studies are still on the observational side, so they fall in the middle tier of the pyramid in terms of level of evidence, and they fall within the analytical arm of the observational studies. So a cohort study is one in which a group of subjects are selected to represent the population of interest and are studied over time. Much like a cross-sectional study, information is collected about the outcome of interest and exposure to risk factors, but in cohort studies, subjects are followed over time. An example of a cohort study is if we wanted to look further into the smoking, how smoking was associated with lung cancer. We could find a group of smokers and non-smokers and follow them for a set period of time, note the difference between incidence of lung cancer between the two groups, and then find controls that can be matched by age, economic status, and other possible confounding variables before the study is even performed. So this would be an example of a prospective cohort study, but cohort studies can both be prospective or retrospective in nature. And again, this is just another way to look at retrospective versus prospective. And here's our population here. If we start and choose people who smoke or don't smoke and match them for their different confounders, age, sex, and other pertinent confounders, and then follow whether or not they smoke or don't smoke, and then go on to develop lung cancer or no lung cancer between each of the different groups. If we followed them if we identified at the beginning of the study and followed them over time, this would be prospective. But if we went into our records and saw who had lung cancer and who didn't, and then went back in time to see if they smoked or if they did not, and found controls for each of our patients who did have lung cancer, that would be an example of a retrospective study. The benefits of cohort studies is that if they're prospective, we can establish the timing of events, leading to less recall bias compared to case control studies. They're good for the study of rare exposures. They can measure the change in exposure and outcome over time. And because we know that sort of the timing of things, we can give some indication of causality between exposures and outcomes. And we can study more than one outcome at a time. And the incidence of the outcome can be measured. The limitations of cohort studies is often patients are lost to follow-up. Controls may be difficult to identify. The exposure could be linked to a hidden confounder. It's difficult to, if not impossible, to blind patients in these studies. And there's no randomization, allowing for confounding and bias to affect our results. And if we're studying a rare disease, we often need a large sample or a long follow-up period. Now that we've talked about a majority of the observational study designs that are available to researchers, we're going to briefly talk about the experimental study designs that are present in clinical research today. And the main one, or the gold standard, is considered a randomized controlled trial. As I mentioned, randomized controlled trials fall under the experimental arm of clinical research studies. An example of a randomized controlled trial, which is an experimental study where the effect of an intervention is assessed by collecting data before and after an intervention has taken place, is one where they looked at the efficacy of vitamin D as a supplementary treatment for tuberculosis, and they did this in a double-blind randomized controlled trial. These trials are carefully planned experiments designed to limit bias and confounding variables within a study. So they randomize the subjects and they blind the clinicians or the people collecting the data, so no one truly knows who got what treatment. And so it attempts to limit bias and confounding as much as possible. And these studies compare the effectiveness of an intervention between the patients who are chosen to receive the intervention and a control group who do not. And interventions usually are thought of as clinical treatments, but can also be educational interventions as well. such as health promotion leaflets or packets. The benefits of randomized controlled trials is that the unbiased distribution helps limit bias, selection, recall, and allocation bias. The randomization also limits the effects of confounding because the distribution of confounders are randomly dispersed across all of the different participants, and randomized controlled trials can be used to make causal inferences. These studies can also be tailored to answer a very specific research question. And then some of the disadvantages of randomized controlled trials is they can often be expensive and time intensive to perform. They can be ethically problematic at times if the treatment is saving people's lives and people not receiving the treatment aren't being saved, then that presents an ethical dilemma for the continuation of the randomized controlled trial. And often they're not always applicable to large populations. They're usually not, they're very specific, and so you can't apply the causal inferences to the larger population, so they lack external validity. And then it's also difficult because you really need a good knowledge of what level of improvement is clinically meaningful and expected to sort of develop your sample sizes and plan your randomized controlled trials. And finally, sometimes there's high dropout rates when the intervention has an undesirable side effect, or there's little incentive to stay in the control arm. So that's a brief overview of a very complex type of research design, randomized controlled trials. And again, we have an additional short article that you can read on randomized controlled trials and gain more information about them. To finish out this lecture, we're going to briefly talk about systematic reviews and meta-analyses. These are studies that are utilized to do an exhaustive summary of the literature that's relevant to a research question. A systematic review aims to provide a summary of the current literature and the results. They look to see which studies have the best methodology and then summarize those results in a way that's pertinent to the review question. An example of a systematic review is given here, where the authors reviewed the literature to gather data on typhoid and paratyphoid fever and look at the mortality and morbidity rates reported in the literature, and then grouped these morbidity and mortality rates into regions, and then developed regional incidence and mortality rates were estimated across the globe. The benefits of a systematic review is it provides an up-to-date summary of the recent literature. It's a good starting point for developing a research question further, and it can be done without IRB approval, but it should be noted that if you're going to perform a systematic review, it's very helpful to have a librarian help you to make sure that you've searched all the databases and collected all the up-to-date literature that you're looking for. Some of the limitations of a systematic review is, as we mentioned, those studies that have positive findings or significant findings are often the ones that are published. So there's publication bias present in systematic reviews, and the information from systematic reviews can become outdated very quickly. I think COVID-19 is a great example of that. There's so much research coming out every month all over the world on the pandemic that what you gather in 6 months ago may be outdated by the time you go on to try and publish your systematic review. A subset of systematic reviews are meta-analyses. In addition to summarizing the literature on a specific research question, meta-analyses go on to perform statistical analysis of the individual studies grouped into a larger study. So if you had 10 studies that are shown here, and they all had a similar statistical measure, such as an odd ratio, which is shown off to the right, a meta-analysis then pools all of those studies and their numbers together to develop an overall odds ratio. So it increases the N, or the power, of a lot of smaller studies together, and can provide a better understanding of the effect of how, say, a BCG vaccine can prevent tuberculosis. Some of the benefits of meta-analysis is that the results can be generalized to a larger population, and the precision and accuracy of the estimates can be improved because more data is used, which increases the statistical power. Some of the limitations is that it requires advanced statistical analyses, and then in addition, if you're doing a meta-analysis or if you're analyzing data from poorly performed studies, this may yield inaccurate results from the poorly performed studies. And then again, we see publication bias because we're only collecting the data on the studies where there was a pertinent or significant finding, and those that did not have them are not being published or not being included in our analysis for the meta-analysis. So in summary, we've discussed a lot of different types of clinical research studies, and we gained an introduction to what clinical research is. And we went on to discuss the benefits and disadvantages of each type of study. There's a lot of information that's been provided here in the lecture today. You're not expected to understand it all at this point in time. And we've provided, when possible, additional articles that you can read about the different types of studies and their methods. And that will all be available and is all available on campus now. Feel free to reach out to your research mentors if there's a specific type of study that you have questions about, or reach out to myself and we can try to provide more clarification.